once again, I welcome you to this webinar. My name is Alice Mutebi Kayongo. I work with the Center for Global Health Policy and Politics at Georgetown University's O'Neill Institute for National and Global Health Law. I am part of the team that has been put together this webinar, but also most importantly, part of the team that makes up the Diagnostics Equity Consortium. I do welcome you to this third session in three-part study club series that is focusing on the evolving tuberculosis diagnostic landscape and strategies to expand TB testing coverage. For those of you who have been following, you are aware that this is the third and the last part of the three series that we have been holding. And this session, as always, it is organized by the Diagnostics Equity Consortium, or you can call it DEC, DEC, as well as the Global TB Community Advisory Group, or you can call them Global TB CAB, Community Advisory Board, not group, Community Advisory Board. In this third session, we will want to, talk about or dive very deep into trade-offs that will have to be made in choosing TB diagnostics for the national diagnostics networks nationally, and what communities want most. So basically, while we have so much for you in store, we also want to hear from you on what communities really want. And to help us explore today's topic, we are joined by a distinguished panel of experts with me who will be able to unpack the benefits of near and point-of-care TB tests that can be that can actually reach more people with TB. The panelists will also dive into the trade-offs and considerations as we assess the capabilities of the diagnostics pipeline. And just briefly, before we dive into the day's agenda, I just want to mention just a small bit about the Diagnostics Equity Consortium, which some of you have heard about, others have not heard about, but I will assume that we haven't heard much about it, and I will take this opportunity to give a 1 to 2 minute brief about the Diagnostics Equity Consortium, which is basically one of the organizers behind this series, working together with the TB CAB. And the Diagnostics Equity Consortium basically brings together civil society, affected communities, and experts to advocate for better diagnostics access, particularly in low and middle income countries. This consortium is hosted in partnership with PATAM, which is a Pan-Africa Treatment Access Movement based in Zimbabwe, working collaboratively with the Center for Global Health Policy and Politics at Georgetown University's O'Neill Institute for National and Global Health Law. And I just want to end off my brief about DEC by letting you know that we have 4 major work streams in which we conduct our activities. The first being the DEC study clubs, which is the reason that we are here today, basically bringing actors together to be able to explore the different issues around access to diagnostics. We also have the second work stream as the Speed Up Scale Up, or you can call it SUSU, SU, which is an initiative that is focused on timely engagement and strategic scaling up of new diagnostics. The third work stream is on Diagnostics Policy Lab, which is basically an accountability platform aimed at tracking, measuring, and improving national policies around diagnostics. And lastly is the National Accountability Framework, which is it basically focuses on government engagement to be able to ensure ambitious goals for the distribution and utilization of diagnostics across health priorities. I know that I have rushed through that, but we will continue talking about DEC anytime, all the time. Today, I want to focus much more on what we have in store for you, which is about speed up, scale up, benefits and trade-offs of a point-of-care testing. And like I said, to help us unpack what we have today is a panel of experts with us. We have Blossom Makubalo, we have Olaide Akani, and we have Nazir Ismail. To take us through our first session, which is trade-offs and considerations for point-of-care testing, we have Professor Nazir Ismail, who is not only a professor, but also a medical doctor and the head of Department of Clinical Microbiology and Infectious Diseases at Wits University and NHLS's Charlotte Maxeke Academic Complex in Johannesburg. Now, I will fail to pronounce some words, but please bear with me. English is my fourth language, I guess. So anything that I do not pronounce right, just please bear with me. Just to let you know that Professor Nasir is also formerly led the diagnostics team at the WHO's Global Tuberculosis Program in Geneva. And like I have always said, we will always ensure that we are bringing you the experts to give you the best information on what is happening in the diagnostics arena and what we need to do moving forward. So without wasting any more time, I want to hand over to Professor Nazir to take us through trade-offs and considerations for point-of-care testing. Over to you, Prof.
Thanks a lot, and you did a fantastic job on pronunciations. Well done. All right, so I think we can get straight into it. Second. 1 minute. I need to, is that full screen for you now?
Yes, now it is.
Okay, great. Thanks a lot. Okay, so good morning, good afternoon, good evening to all of you. Thanks for joining today. And I think before just getting into the details, I want to just highlight a few issues related to diagnostics, so just to set the scene. And I've, updated this slide that I've normally used because the Global TB report was issued late yesterday, so I don't know if you all had seen it. Really providing the latest data from 2023 on where we are in terms of the diagnostic gaps. And I've now added the last column that says 2023. But there's a few key messages out of this slide. That there's clearly gaps all along the cascade. So as we look at what's estimated, what's diagnosed, what's bacteriologically confirmed, what gets rifampicin testing, what gets fluoroquinolone testing, etc., the performance has been generally poor. There has been some improvements in some areas, for example, the access to WRDs, going from 38% to 47%, and marginal improvement in the last year to 48%. But the expectation is that by 2025, all notified cases would get a WRD. So just want to highlight that there's clearly gaps all along the cascade. And what's very critical is that diagnostics need to be prioritized in terms of budgets and future planning. So that's the first message. The second is, and I think people might be familiar with this, is the WHO standard on universal access to rapid TB diagnostics. And particularly what I'd like to draw your attention to is the graph on the left. What you see is that indicator I mentioned in the previous slide and its trajectory. It's very slow uptick of these rapid molecular tests. And we could see in the last slide as well was a very minor improvement as such. And what the green line at the bottom is actually the number of microscopy sites, which is very widely distributed, that even have technology available like the WHO recommended rapid diagnostics. And that's another key issue. And what's very clear is why we're failing is really issues related to diagnostic access. So I think the first is that we need to do a lot more and invest a lot more in diagnostic. The second is we need to address the diagnostic access issue. Microscopy is still far more widely available than most of these new technologies. And that's the barrier we need to really get through and break. We know that microscopy is far less sensitive and misses key aspects of TB care. So just for your information, also with the release of the Global TB report yesterday, we have also in parallel added in a dashboard where the parameters for the WHO standard are now being populated by countries on an annual basis. as part of the data collection system at WHO. And you'd see now on the data page, you'll find a hyperlink to this WHO benchmark of universal access to rapid TB diagnostics. And not all countries have sort of updated in this past year, but it's been a very last-minute request of data in this new initiative. But we expect from the subsequent years, countries will be populating. But I think this is an important monitoring tool related to the diagnostic standard, and something that the advocacy groups should be keeping a close eye on as countries start reporting. Going specifically on the universal access standard, there's 12 benchmarks, but for today's discussion, there's 3 I wanted to primarily point out. The first one is on WRR, the access in primary healthcare, and that's in the step 2. The step 4 in terms of timely delivery of results, and then the step 3 related to universal DST. And these are expectations that everyone should have access as primary healthcare, that results need to meet the benchmark for timeliness, and then obviously that every person does get the spectrum of resistance testing required for their care. So these are the key parameters, and we need to be focusing on these 3 aspects as we start these discussions. And when we're talking of access, and I think this point of care, near point of care technology is really sort of honed in on this concept around accuracy versus access. And this was an important parameter that was considered in the latest target product profiles from WHO. What it illustrates is, on the right-hand side, you see the blue is basically correctly diagnosed, and the green is missed, and the black is false positive or false resistant. And really what it speaks to is a very accurate test on the right-hand side with very limited access at only a quarter of the population. And on the left-hand side, you have a less sensitive test, but it can reach a much larger population. And what you notice is overall that your blue box is actually larger on the left than on the right. And that's really the trade-offs that really need to be sort of thought through in terms of what we're talking about in near point of care technologies. And just to be clear, what we talk of when you're talking of near point of care and point of care technologies, at WHO we issued now the target product profile. And what needs to be very clear is that we've separated point of care from near point of care. A point of care is really aimed at being a sort of a rapid test, like a pregnancy strip test, a COVID rapid type of test without any equipment and could be deployed anyway, without much skill required. Where the near point of care is sort of that middle ground that does say that you could have a battery operated type of instrument. You need some very basic skills, but you don't need a lab person to run that technology. And you definitely don't need specific infrastructure. And what we're really honing in on is on the near point of care and point of care technologies. And just also to know that TPPs are meant to provide a 5-year landscape to guide development and new technology. And I think what we're talking of is something that is on a cusp, but not there yet. And I think we need to be cognizant of that. So coming to the questions that were put to me, the question of should we be using swabs or sputum? And I think obviously in terms of swabs, there's obvious advantages. It's the convenience, especially in the ability to provide a sample particularly. So we know particularly in people living with HIV, sputum scarcity is an issue. So they might not be productive or productive at that point in time. So scarcity of sample is an issue. And the second is related to things like urine, where privacy becomes a problem, right? The second is that we know that most of the new technologies that are coming up, and I think you've heard about them, are using swabs as the go-to sample type because it's just easier to process. And the expectation is that because of the sample type, we expect that larger numbers of people could be reached with this type of sampling approach. So there's a lot of excitement and hope and hype around swabs, but I wanted to just draw some balanced views on it. The first is that the swabs have been used in very strict research conditions currently. They follow a very standardized protocol for performing the swab testing. And I just want to highlight, this is what's recommended on the standardized FIND protocol. So it says Brush from the back of the tongue as far back as possible without creating a gag reflex, using a timer swab for 30 seconds with a focus on the back area of the tongue. So, not being facetious, but 30 seconds per person rubbing on your tongue is not a practical thing. So I think there's some levels of refinement and true performance in the field is a little bit of an unknown in my view. The second is that we know that the tongue swab has less bacterial load, and therefore the sensitivity and the performance of the test might be lower. But we've also, as I highlight, we may be willing to accept lower performance if we can get better reach. So there's a pro and con. But the biggest unknown is really how much of loss in a real programmatic sense would there be. And the concern is that you don't want to end up spending money on a certain area and you miss important cases that are right in front of you. So there's this balance of the opportunity that's there and also some rationality related to swabs as a sample type and how it needs to be collected and its potential lower performance. But the question that I'd like to sort of counter back to the question I will ask is, why not both a swab and a sputum? Or what some have now recently tried is swabbing a sputum. So you end up with very similar kind of overall outcomes. So I think it's not a question of swab versus sputum, and it's not a one-size-fits-all. It's about a balanced approach, and you choose the best sample available at that point in time. The other question related to swab and sputum is like, we currently use sputum as a go-to current specimen type. The question is, are we ready to make a massive shift from sputum to swab? And I think in time it would be there, but at this stage, I'm not certain that we've broken through some of the barriers that are there. And those things, especially on the research side, need to be worked out. But having said that, I do believe that swabs will be the sample of in time going forward. And we need to be setting that ground and advocating for more qualitative and stakeholder engagement related to understanding this approach and actually getting countries involved in a lot of these studies to understand it in its local context. The second question I had was around accuracy versus yield. So I've highlighted that the accuracy versus yield dimension does show important value. But I think there's a few things that we just need to consider when we're talking of accuracy versus yield. The one, as I mentioned, is the lower sensitivity. So we know relative to sputum, it's about 20% less sensitive, but maybe 15%. But I mean, it's definitely lower than sputum. And it's just because of the bacterial load, essentially. There's a lot of effort towards optimizing the swabs and having foam swabs and a variety of other things with other equipment that's required. And then as you start adding the complexity, you're reducing that accuracy gap, but then you're adding more complexity to this whole equation. And that's the trade-off, right? And the last thing around the consideration of all these statistics that are coming out and people are presenting is that it's often relative to a sputum-based test on an expert, which is not 100%. So it's again 90% of 90%, and we just need to be cognizant of those factors. But anyway, I think in terms of, we know it's less sensitive, and I think that's a given, and we can accept that. The question is, does it really matter if it's less sensitive by 10 or 15%? So for me, the case scenario that's quite real is that if I'm a person with potential TB and I'm coughing, I can produce sputum, and you offer me a tongue swab, there's a chance that you could miss my diagnosis. And that's the question. That's the first question. And the second is, if you tested me on a sputum-based sample, then I would have got my rifampicin result. So again, there's a trade-off in these two aspects that we need to be very cognizant of and really find some pathway in between, a fair balance that looks at sensitivity, but also looks at the individual rather than just making a blanket view. The other question around, yield is more important. And yield is probably more important when you've got very highly accurate tests. Like for the world in HIV, we know that tests have like a phenomenal sensitivity and specificity, and accuracy becomes kind of a moot point, and it's all about case detection. The problem we face with TB is that there's complexities with the tests that are being provided. There's issues related to false positives and false negatives. And just to remind ourselves that the false negatives are obviously lack of diagnostic closure. You could continue to transmit and worsening health outcomes if the diagnosis is missed. And the false positive side, obviously the adverse events that come with TB treatment, the stigma, and also with the wrong diagnosis. I mean, there might be something else wrong with you and you actually been mislabeled as such. What we at WHO tried to push for is not necessarily incremental, not yield, but actually incremental sensitivity and specificity. And that's something that we've done actually recently with the concurrent testing for VLHIV in children. It's a probably more accurate way and more safer way of dealing with things, is that you're aiming to get incremental accuracy and specificity. So it does factor in accessing certain populations, but it's done balancing risk of false positives and false negatives. So in sum, I think around the question on accuracy versus yield, I think, when we looked at the TPP and what we've proposed for the TPP target, which are definitely lower than what's required for expert, what's critical to appreciate is that it is premised on a few fundamentals. The acceptability of a lower sensitivity test is that it would make a difference to the person. It means there would be a reduced loss to follow-up. Number two, it's really addressing people that cannot produce sputum. And that's my concern, is that we don't really actually have good studies that are addressing these types of people that are not sputum productive. And this data doesn't exist, and all the studies that they're presenting on don't include this population. And this is a critical population. So the second premise is not being dealt with. And I think the third that is sort of being addressed now is acceptability to individuals. Again, the actual process and the procedure needs to be a little bit optimized in my view. And the last question that I was given is basically the question about drug resistance. So largely, most of these new swab-based tests do not include rifampicin testing, while the WHO does require universal DST, and it's appreciably why that is the case. What I'd like to highlight is that although WHO requires universal DST, it doesn't prescribe that it has to be all in one test. And having it all in one test is obviously advantageous, but it's not a fundamental requirement. We know the importance of mucin resistance obviously has consequences for patients, for close contacts. We know that the past technologies that have been introduced, like Expert and TrueNet, have really made a huge dent in detection of rifampicin resistance, and we don't want to lose that. But let's come to the balance now. So how common is rifampicin resistance? On a global level, it's about 3.3% in new cases, and in previously treated around 17%. But we know that it's very heterogeneous. There's many parts of the world that have a prevalence of less than 3%, and in like Eastern Europe might be about 50%. So I don't think we can treat each country the same in how we go about it. And we know, for example, in Rwanda, for example, there have been repeated publications around high rates of false positive rifampicin resistance, because I think their prevalence is just over 1%. So even an excellent test will perform poorly. So we also need to balance that in different populations and that. And essentially, in those kind of circumstances, an algorithmic confirmation for a positive that comes up could be reconfirmed. So there are solutions on how you can deal with those through an algorithm rather than necessarily through a test solution. The second is the non-inclusion. By definition, so if you don't have rifampicin included in your test, and this is actually currently practiced with TB-LAMP, with the low complexity net, which is basically the TB-LAMP of the past. We have recommended technologies that don't include rifampicin and have highlighted the need for reflex testing to, once you got a positive, to reflex and actually confirm that at least test for rifampicin resistance. It's interesting, even the TrueNet and the Roche assays for TB, which are also automated systems, actually have a built-in reflex. It detects TB and then takes the DNA for another test. So it's not sort of untoward, so long as we have a reflex algorithm or reflex confirmatory algorithm that can address these gaps. But having said that, we know in the real world, often gaps just permeate and become worse. So it's not just having the algorithm, but actually having the M&E in place to make sure that every person, and we monitor and make sure that if a person diagnosed with TB, did they get the rifampicin, and actually identify where the problems are and solve them. So moving to my, and I think this is just a slide from the Global TB Report highlighting, largely there's a lot of lower prevalence areas, if you look at the yellow on the top, where I think, these considerations of not absolute requirements for rifampicin as within a test, but within an algorithm. And then just to conclude, and I know I don't have too much time. So I think there are a few key messages from my perspective on the point of care, near point of care tests. I think in terms of point of care, we have LF-LAM, but I'm not certain whether that has reached its pinnacle in terms of becoming a test for all people with TB, not just people living with HIV. But I do believe within the space of PLHIV, I think we will see some positive shifts in that direction. But the main focus is in this near point of care group of technologies. So there's a few key things that I'd like to just summarize in this last slide. The first is TB diagnostics need to be prioritized. I think what I'm very concerned about is that we've seen that, I think countries like Nigeria, I think the budgets will probably be reduced in time. And it's at a point where we're really finally getting traction and moving forward. And this donor dependency is a particular issue. And my concern is that the TB diagnostics may suffer, and this is sort of the starting point of care. So that's something we need to sort of actively advocate for. The second is, I think the diagnostic access has become a very critical issue. And as I highlighted, we have now in the WHO standard mapped out, I think, 3 things that I think would be important for the community to drive forward. And I think this should become a standard for even all partner organizations to start reporting against. So while they're implementing and supporting, whether it's Global Fund or USAID, they should speak to these PHC access issues, the timely results, and universal DST, and how their work is contributing to closing these gaps. We know the new technologies will help close these gaps, but I still think that even with the current technology, we should not lose time. The third, related to the broader messages, is that this focus on the near point of care and near point of care technologies definitely needs to be supported, but supported by robust evidence that is meaningful and has patient-important outcomes. Because that is really what would help strong recommendations. Otherwise, we end up with conditional recommendations for 10 years and don't really move the needle forward very far. Now, specifically to the question around swabs and these near point of care technologies, I really think it's a mute debate around swab versus sputum. I do think we need both, and I think this proposals around swabbing a sputum where technology might not be able to cope with a sputum is probably acceptable and something we should always bear in mind because it provides better performance and better care for patients. But I don't think it's not just swab or sputum. It's like urine and stool for children, and so I don't think we should be sort of limiting ourselves to this kind of debate. The second around accuracy versus yield, I think incremental accuracy that can improve access and reduce loss to follow-up, and that is proven that really benefits people, is what we really need. It's not so much about the accuracy, it's not about the yield, but it's really about the impact that we want to see and that we would like to realize. And then last, as I mentioned just now about rifampicin resistance detection, universal DST is a requirement. We should adhere to it. It has made a big difference. But this can be dealt with, especially for many parts of the world where resistance, particularly in new cases, might not be very high. I think reflex testing with MNE is an alternative. If manufacturers do include rifampicin, that'll be awesome. But I think, we're facing many challenges, and I think we should, work on algorithms as well that could fix the problem if these issues do arise. So that's it from me. Thank you very much. And I hope I haven't overdone my time.
Not
Thank
at
you.
all, Prof. Thank you so much. We do appreciate the knowledge that you have shared with us today. And I know that several of us here do have some questions. Just to remind us that we have a chat box. Please place your questions there. However, just before we move on to our next session, I will give it maybe 1 to 2 questions to Prof to be able to respond to, and then any other questions we will be responding to them in the chat as we go on. But also as a reminder, please remember that we do have simultaneous French translation. Feel free to use your pen at the bottom of your Zoom window so you can be able to access the French translation. So I'll open up for 1 to 2 questions, and I see Sharonan has 1 question. Yes, Sharonan.
Hi, Nazir, thank you so much for that. That's incredibly helpful. And I know it's early days where WHO doesn't have the data yet. The studies have not been concluded to provide guidelines. But what are you thinking would be the use case? Because obviously, when oral swabs were first talked about for TB, many of us got excited about being able to take those swabs back to household contacts, back to family members. Even if somebody tests positive, here, take these. So is that totally out of bounds? And
So,
right
right.
now, do you see that this will remain for the time being a facility-based test? And what do you think would need to change for that to be out of facility? And my third question is about time. When do you expect data to be submitted to WHO to adjudicate on the efficacy? And I'm so sorry, but I have a fourth question. Given how important it is to have drug sensitivity testing, do you imagine a world where you still collect sputum and perhaps it goes to central or district for either GeneXpert or one of the what we hope will be competitive platforms, or even sequencing at the national level at the referral lab? Thank you.
Certainly, oh, brilliant question. So, right. So the first one in terms of the use case. So I think there's two potential use cases the way I see it in terms of sputum, of swabs. The first one I think would be really driven around hard to reach areas and populations that are struggling with access. So that is a kind of a no-brainer. And I think the situation there, obviously it's against a baseline of smear microscopy. So if that's the only thing available, then I'm certain these tests will do better than smear microscopy. And that would be the comparative we should be getting evidence on, right? So that's the first thing. The other potential use case that I think has potential value, and you'll see it in the new TPP coming out for screening, is the utility of a low sensitive, highly specific screening test. Right? And the rationale behind it is often screening tests often thought of as a high sensitivity test, but because of the lower prevalences of TB, this could potentially solve an important question and problem, right? So that's the one thing. I think that household contact you're talking about, I mean, a lot of them are smear positive, right? These household contacts, even these active case finding situations, you're finding quite a lot of people that are smear positive, and if you could do something like quick and easy, you might not pick up everyone. You could refer those that are negative elsewhere, but you could get an answer relatively quickly. Those are two use cases I think are kind of like more concrete and more real than all the exciting things that other people are talking about. And in terms of these technologies of near point of care, I think at present it would be facility based. And what shocks me the most is that two things. The one is that even access at primary healthcare level is extremely bad. So before even jumping to communities, we have people walking in that are ill, right? And to be honest, just providing a primary healthcare level, that's the one pain that I see. The second pain that I see as well is that when I talk of primary healthcare, it is very poor, right? In many settings. I mean, South Africa, post-apartheid, that primary healthcare system was really strongly developed, and we actually now people can access a health facility within 5 kilometers, right? But it's not true in many parts of the world. So I mean, for getting into what they call primary healthcare, it's actually even providing services to people close to where they live, right? And that's the second part. So in terms of facility, so that's the question. The second one was related to, one second. The timelines for these changes, right? In terms of how quick this could happen. And I think that's tied to also the timelines to the data, right? So in terms of, I mean, at WHO when I was there as well, even we've had a lot of discussions with a lot of the developers highlighting that, what are the data needs? I've been absolutely clear with them. Is that, and my biggest concern is that we're trying to advocate for something that's probably less sensitive, and we know it makes sense, right? But we need the evidence, right? It's not on a hunch that we do make decisions, right? That's not scientific basis. So my biggest concern has been a lot of the investigators are taking the easy option of just doing a classical diagnostic accuracy study. And they really need to be doing more programmatic studies, pragmatic studies that show that you can impact on patient care, that you can reduce loss to follow-up, you can make a difference. And so in terms of the accuracy data, we were expecting something in 2025. I'm not sure. To be honest, every time I've planned a meeting, they've always been a year behind, right? So it's either 25, 26 probably that the data will come. My biggest pain is that, like I mentioned, this test is supposed to be very good for people that can't produce sputum. So this is really PLHIV in children. And as far as I know, there's zero data coming for that. Zero. Right? So they're doing it on symptomatic sputum producing patients, right? But so, okay, fine, that's an accuracy against sputum, but that's not the question I'm asking, right? You can answer that question, but it's a separate question. So that's the pain that we're facing right now is that, they're not, and it's been going on for a while. So I think that's something that needs to be addressed. So I think with that, and that's why for me, if you bring that kind of data, you have a strong recommendation, you can move things quicker, right? If it's conditional, let's say we don't know how well it will work on these. And the biggest problem with PLHIV in children is that they're less sputum productive, they have a less bacterial load. And while we're seeing now all this great data about 80% sensitive or 90% sensitivity, in a person that has low bacillary load, I don't believe we're going to get anything close to that, right? Because they're not producing sputum, not. So the thing is, we'll end up looking for all these people. We get lots of negatives, and people start asking questions, what happened? So we need to do due diligence in the beginning, and that's, I think, an important part for me. Then the issue around the DST question, right? So here, what excites me a bit more about these new technologies, the biggest challenge we've had with Expert is that when you tested a sputum on Expert, nothing came out of that cartridge. With TrueNet, with Roche, with a lot of these new technologies, you actually get the DNA out of the test, and that can go into a test. It can go into a reflex test for rifampicin. So you can ship DNA that has no logistical issues. It's stable. You get DNA from mummies 5,000 years ago, right? So it really simplifies the logistics of it and could actually be reflexed onto instruments, whether it's a TrueNet, whether it's a DNGS. You have DNA that could quickly shortcut some of the steps for all those tests and go straight into a second step of a test. So I think that's kind of the paradigm I'm thinking of. And looking at this new therapies that are coming out, right? So rifampicin is still quite key, but I don't know, 5 years from now, the dynamics might change. And the second thing is that, rifampicin is still key, but beyond that, honestly, it's sequencing that's left. If you're on bedaquiline, protonamide, all these new drugs that are coming, there's no rapid test going to be there for them. So for me, it'll be a default TNGS, and having these tests that pick up DNA and send it off for sequencing. And the sequencing technology are getting simpler. So I think there'll be a sweet spot maybe 3-4 years from now that would probably try and bring things a little bit more decentralized in a mid-level kind of space. So I'm not too concerned, but I think the concern would obviously be what we've seen also in South Africa, where the LF-LAM has been pushed hard, and then they do the LF-LAM, and then no further testing is done. So the rifampicin is not being tested, right? Because, we got a TB diagnosis, put the patient on treatment, and then goodbye, right? So that's where now it's good and bad, because it's good in the sense that you got a quick diagnosis. You've actually sorted out an extrapulmonary case quite quickly with a urine sample. But your concern is that obviously it just perpetuates, you'll end up reducing the number of rifampicin cases you detect. But the solution to that is really monitoring. That's why I mentioned the MNE. So how many TB patients did you have? How many RIF were tested? And that should be a basic metric, right? And once you see that dropping, then you find out where you need to retrain or engage those individuals. I know you had 4 questions. I think I've answered 3. I might have missed the 4th one. I don't know.
Yeah, maybe Sharon will help us write in the chat, and I am sure, Prof, you'll be able to respond to Sharon's fourth
Take some more than
question,
one.
as well as a couple others that have come in there in the chat. Please feel free to respond. And anyone else has a question, please place it in the Q&A chat box so that Prof can respond as we go along. So in the interest of time, I will move on. We have just a few minutes to the end of this webinar, and yet we do want to give you all that we actually prepared for you. Coming on right now is my colleague Olaide, who is going to let us know what is it like in Nigeria. What is the experience like in Nigeria? And just so you know, Olaide is the national coordinator for the civil society for the eradication of TB, and an NGO with a mission to coordinate civil society organizations to advocate for increased access to Nigeria's high quality and comprehensive TB services. She's not only an advocate, but also a health correspondent with several health journals. Olaide, over to you.
Hi, good afternoon, everyone, and thank you for the opportunity. I think Professor Nazir's presentation has made my work quite easy. We don't have a lot of time, so I'll just do a quick run of what we have in Nigeria in terms of the diagnostic landscape. And so in Nigeria, of course, we are using several of the WHO recommended tools, and I'll just make a quick outline of that. So there's an AFB microscopy, GeneXpert, TrueNat, TB-LAM, LF-LAM, chest X-ray, TB-LAM, as well as line probe assays that are in use. But one of the major challenges, just as Professor Naziri had highlighted in his presentation, is the issue of coverage. Coverage and access to many of these diagnostic tests remain very uneven, particularly in rural areas with limited infrastructure. So that is definitely a major challenge. And so beyond that, we also have gaps in testing around, suboptimal screening of high-risk populations, suboptimal integration of TB services into the primary healthcare centers, weak referral systems and follow-up, as well as funding gaps for diagnostics. And like he also mentioned, funding gaps for diagnostic tools and supply of cartridges. And like he also mentioned, we have a situation where the TB program is heavily donor funded, so that is definitely an issue for consideration. And then, of course, we also have issues of, like I mentioned earlier, suboptimal use of some of the diagnostic tools, for instance, the TB-LAM, the PDX, they are not as used as some of the other tools. And then we have issues with oftentimes supply of cartridges for, the GeneXpert machines. And even the GeneXpert machines, while there is a serious push to ensure that, probably each of the local governments have GeneXpert machines, some of them don't have enough, and some also are suboptimally being utilized. So those are some of the issues that we have, with TB diagnosis in Nigeria. To the issue at hand, and back to the presentation in terms of, the TB swabs and, the opportunities that it presents for, diagnosis in Nigeria. For me, and looking at, the landscape in Nigeria and what is currently happening, we definitely would welcome, having the TB swab accessible, particularly for children. We still have a major issue with childhood diagnosis of TB in the country. And so having those swabs very readily accessible for diagnosis in children will definitely be a step in the right direction. But the concern, given the presentation that we just heard, is that even when the swabs are available right now, they might still be a facility-based option, which from a community perspective will probably also, limits the what we are trying to achieve, because definitely you want that option to be readily accessible to communities where they are. In instances where communities are not able to access, the facilities, either because they are hard to reach, communities, or maybe there are just issues with accessing the facility itself. So definitely looking to a TB swab option, a swab option that is readily accessible and that can be utilized by communities in the communities will be a way to go for us, as something that is really practicable and realistic. The other issue, which I also wanted to speak to, is the thoughts on whether, I also strongly feel that, when we're looking at the swabs, it shouldn't be an either or, with sputum, with the current test around that are sputum based. I think that we need to have both of them running side by side concurrently, and ensuring that, the swabs are readily available to people who need them, people living with HIV, and children who are unable to produce sputum as readily and as quickly as possible, because for many people, the diagnosis is the entry point into care. And so if those diagnostics are readily available as point of care or near point of care, just like we are proposing, that they can be detected easily, and then, their ability to go to the health facility to be placed on care can easily be addressed. That will be definitely a step in the right direction as far as this is concerned. I think I'm just going to stop there because of our time, given that we also have another speaker, but I'm open to other questions. Thank you. Over.
Thank you so
Hi,
much.
all. I just want to interrupt to say we can keep going after the hour. We want to hear from Blossom, and if others have comments and questions, and thank you for the panelists for being patient. Sorry, Alice.
Thank you, Sharon, and thank you so much, Olaide. So we will right now talk about diagnostics for impact, basically putting people first, and no one other than Blossom Makubalo will be presenting this to us, giving us an experience from South Africa. And Blossom is the Community Engagement Manager at the Oram Institute, where she coordinates partnerships with affected communities on various TB projects. Blossom, over to you.
Thank you, Alice. Yeah, I had slides. So yeah, diagnostics for impact. You can move to the next slide. The time is stressing me because I'm looking at my clock. It's like a few minutes. So why should we care to test more people for TB? For this reason, I'm going to give you a community overview. South Africa is a high burden TB country. We have a serious issue with 5% resistant TB. So if you're thinking of new testing methods, we must always consider, well, it also pick up 5% resistant. 54,200 people died in South Africa in 2022, and 280,000 people fell ill. And TB disproportionately impacts people living with HIV in our country, with 60% of deaths occurring in people living with HIV. So for us, I was thinking of this is kind of like a double-edged sword for us. In the sense that our TB screening, it's then prioritized towards people who are living with HIV. And as a result, we miss people who are not living with HIV for TB screening, and that is where a lot of undetected TB is seen. And we have an incidence of 468 per 100,000, which is considered high. So this topic really matters for us. We need more testing tools, and we need to test more people. Next slide, please. You know what makes South Africa unique? South Africa is an upper middle income country with the highest income inequality globally. I think Prof also mentioned this briefly in his presentation. We are sitting with a legacy of apartheid, which resulted in inequality. And in South Africa, TB inequitably affects Black and colored South Africans living in poverty. We all know that TB is a social disease, and vulnerable populations are at greater risk of developing TB disease due to socioeconomic conditions that also restricts access to healthcare and diagnostics. They may be living in informal settlements where they are far removed from health facilities and cannot travel to health facilities. So that does impact the access. There's no point in having diagnostics, but people cannot access the diagnostics. What drives TB in our country is poverty. We've got high rates of poverty, unemployment, especially youth unemployment. We've got food insecurity issues. We've got malnutrition, with poor housing, substance use, smoking, biosocial factors like diabetes and HIV, as well as the undetected TB is also driving TB in South Africa, which says to me we need to find innovative ways of testing people and getting to the undetected cases of TB. We had the first national South African TB prevalence survey in 2018, and this survey revealed that 58% of survey participants with TB disease reported no symptoms. But when a chest X-ray was conducted, they could the chest X-ray could pick up bacterial. I'm not good with medical terminology, but so we cannot rely on symptoms only. And currently, what we see, we know that if you present at the facility, you do the TB screening symptoms, and if you present with symptoms, that will trigger a TB testing. So, and the survey, interesting, also revealed that there's a higher TB prevalence in males than in females, and with males displaying poor health-seeking behavior. We see this a lot with males not presenting at health facilities. By the time they present at health facilities, the TB disease is advanced. We also see a higher prevalence in the ages 35 to 44, as well as older adults. So we need to start thinking about innovative ways of reaching those populations. We should not leave anyone behind. Next slide, please. And then I'm just going to briefly go through the types of common types of screening that we see in South Africa. We've got facility level screening, where screening is conducted for all clients seen at the facility. We've got a symptom screener checklist that is administered. Ideally, it should be all clients presenting at a facility should be screened for TB. And if there's a positive TB symptom, that will then trigger TB testing, but we all know that we cannot just rely on symptoms only. You also get community level screening, which is conducted at a community level. I love this. This is about bringing services to the community, and this is part of outreach programs, which includes your household contact tracing, your door-to-door campaigns, as well as your wellness campaigns. What is problematic with this? It's not consistent. It's usually triggered by our health calendar days in South Africa. For example, during the month of March, you will see a lot of activities, outreach level screening, because it's World TB Day. So it doesn't help if it's just on a routine basis. It should be all the time. So I see that as a gap. And some of the gaps in screening, like I said, it's the underdetection of TB in certain groups, example, substance users, who because of the substance use will not present at a facility. Because currently our system is made up if you have to get to a facility to get tested. And then people without HIV. This was actually picked up in the prevalence survey I alluded to. Men without HIV, working men for that matter, were found high rates of TB disease was found there. People aged 15 to 44, both men and women, and these are working age people. You can imagine less able to access screening services, because screening services, it's during the time which is supposed to be at work. And many of the South Africans are employed in the informal job market where they do we call it piece jobs, and cannot always access facilities. So we also need to explore other innovative ways of how we can screen more people. We need innovative active case finding needed. There's also what we see is people ignoring symptoms. They might have they have symptoms of TB, but they ignore it, and this is usually associated with the TB stigma. Yes, it's 2024, but we still see a lot of TB stigma. We still need to do a lot of education and awareness in our communities, because stigma exists because of people not understanding the disease. We also need a lot of health education. There's a lot of gaps. Usually what happens is you get your sputum bottle and you request it to produce a sputum, but there's no health education that goes into that to explain to the clients why they're being asked for a sputum, and after they've collected the sputum. Also counseling just to explain, if your results come back TB positive, please make sure you come back to the facility. So I see a lot of gaps there. We can learn from the HIV where we used to have pre and post test counseling, and we don't see that for TB. Next slide, please. And then this is just the health facility screening algorithm, where you present at the facility, you get checked for your, you get screened for TB symptoms. If you have a previous TB disease, or you have someone in your household with TB, or you're living with HIV, it will then be a yes, and a sputum is collected. And if it's a no, you then and there's TB symptoms present, sputum also gets collected. But like I said, this is problematic because it then solely relies on symptoms. We need to do a paradigm shift. And then the next slide, please. I love this community TB screening. In an ideal world, it would be happening, but we don't live in an ideal world. You all know in South Africa, we're a country with a lot of resource restrained staff challenges. So community TB screening also usually happens during those campaigns where there's World TB Day. There'll be an increase of activities focused on TB, and we should not park TB screening and TB awareness only for the month of March. It should be an ongoing thing, because we do have a TB problem in our country. We are a high burden country when it comes to TB. In the interest of time, we can move to the next slide. Then I just made some notes on facility level screening versus community level screening. Screening in communities, it brings services to the people. Alice asked when she introduced us, what do people want? Alice, the best people to ask what they want are the actual community members. Communities know what they want, and they know how they want it delivered. So we should have more, we should take it back to our communities. And then, with community level screening, it takes away the burden of traveling to the facility, because we know we have a big unemployment and poverty problem in our country, and people cannot always present at the facility due to those restraints. They don't have taxi fare to travel to the clinic, and some of them are too far removed from the clinic. Then you also get, with regards to facility level screening, it's also, it identifies people who present at the facility. My question would be, what about people who don't present at the facilities? How do we reach them? We should be able to reach everyone and not leave anyone behind if we want to end TB by 2030. And then community level screening, reach populations who live far from facilities. Example, populations, people who are very mobile, they don't stay in one place for a long time. Also people who are homeless. And then TB stigma impacts community level testing. We see this a lot where people know there's TB screening happening. People do not want to go and screen because TB is associated with HIV, where people feel, oh, if I have TB, people are going to think I also have HIV. So stigma still exists, folks. It's 2024, we are in the era of AI, but TB stigma still exists. And then you also get community and facility level screening. It's mostly driven by the Department of Health or implementing partners. I would love to see a situation where it's driven by community-based organizations. They take the initiative when it comes to that. I loved last year during World AIDS Day, where the slogan was, let people lead, let communities lead. It can also be adapted to TB response, let communities lead. Next slide, please. And then I'm going to dwell onto the test. Prof spoke about the test. So what happens in our country, you get to the facility, you get screened for TB symptoms, and then a sputum is collected. We already know sputum is problematic because not everyone can produce a sputum. And our tests are also processed at the National Health Laboratory Service. In June, we had like a cyber attack on our NHLS services. I hope we have learned lessons with regards to that, because our TB testing services was brought to its knees. There was like basically a standstill of services. So I hope with these lessons learned with that. So the next cyber attack does not cripple us like the one we had in June. I think Prof would be aware of that. And then now we've got the expert MTB RUF Ultra that is used for testing. But like I said, we also have chest X-rays, which is recommended in certain groups. And the reality is we don't always have chest X-rays accessible to people. So that I see as a gap. Next slide, please. And gaps in diagnostics. Not all clients can produce sputum. The imperfect sensitivity of existing diagnostic tests that can misdiagnose in certain groups, especially people living with HIV, people who are immunosuppressed for other reasons, for example, and children as well. And the above groups are also more likely to have extrapulmonary TB, which is more challenging to diagnose, and it needs biopsies and lower sensitivity tests on non-sputum specimens. And then a good question to ask is urban versus rural settings. We should not, when we are bringing in these new technologies, not forget rural settings, because rural settings does not always have the infrastructure to accommodate these modern types of tests. So we don't want people not to access tests because they happen to live in Umkhanduli in the Transkei with one services for everyone. And then what we currently in my area, we're seeing a lot of sputum bottle shortages, and that also impacts testing. So yeah, we run out of sputum bottles. We also run out of the specimen bag shortages. And then sometimes what happens at facility level, the sputum bottle is provided to the client to take home. If the client cannot produce sputum at the facility, they advise to take it home and try and produce sputum in the early mornings. And what we see happening there, the clients don't always return to the facility for various reasons. It can be financial reasons. It can also be reasons of they have other responsibilities to take care of, so social reasons. And then, like I said, undiagnosed TB is a major driver for TB. Next slide, please. So we need more tests. And then, please, guys, I'm urging, let's bring screening to the people and let people lead. It always amazes and surprises me that there's not a lot of investment with regards to social behavioral research, a lot of qualitative work for us to find out what are the reasons why people don't want to test for TB. For example, the issue with men, we should do a lot of social behavioral work to find out, because TB is a social disease and we need to look into the social aspect as well, not only a biomedical response, but the response must be holistic. So yeah, thank you everyone.
Thank you. Thank you so much, Blossom. And I want to thank all participants for holding on to we should be done in the next 5 minutes. And for sure, we have had a very lively Q&A chat box which is still going on. Prof is responding to a number of questions. Please feel free to pose some questions for Olaide and Blossom as well. But at this point, even before I close, I just want to give an opportunity to just one person to be able to go off mute and ask a question so that either Olaide, Blossom, or Prof can be able to respond to your question, while other questions will be responded to in writing. Anyone? We don't have so much time. You'll need to grab the opportunity as soon as possible. Yes, Vanessa.
Yes, hello, good morning, good afternoon. Can you hear me?
Loud and clear.
Yes. So I know that we've talked quite a bit about the potential of swabs and the combination with sputum. I wanted to get thoughts from the panelists about looking at biomarkers. There's been quite a bit of chatter recently about biomarkers that can be identified in blood and be measured from a finger prick of blood, for example, as another form of a, potential point of care, or even for screening in communities. And yeah, I wanted to find out what people think about the potential of that, both for community screening and at point of care, near point of care diagnostic development.
I can try and answer that. So, to be honest, the biomarkers have been a very heterogeneous. I think the results have been very heterogeneous. So often you find that studies are done and they often optimize it in a certain locality and show good performance. But when you start replicating it in different settings, those can often be very variable because of host genetics in different communities. There's two parts. I suppose the one is related to obviously host-directed type of technologies. And those have variable performance depending on population, and you really need to find a host marker that's very universal in different types of populations. Then the other thing that actually detects something that's kind of material in terms of protein or a signature of TB or something like that. And those are a bit more specific and less heterogeneous, but then the sensitivity is often a problem because you might not find much of the TB signal in a blood specimen, but you might find it in urine for that matter. So I know there's a lot of hype, but I'm a bit cautiously optimistic that these technologies need a bit more refinement and broader studies to see how they work.
Thank you so much, Prof. And as you can imagine, these webinars would never be as interesting or as insightful without participants, but then at the same time, they wouldn't be as insightful without our experts. So at this point, I want to thank our panelists so sincerely for making the time. And I know that there are several questions in the chat box, which some of which Prof has been able to respond to. Others, please feel free to direct them to DEC or TBCAB. We will be able to respond to those questions. And just as an announcement, we will be sending you recordings of the entire the 3 webinars. We'll send you the recordings, we'll send you the slide decks so that you can be able to, be part of the discussion virtually. And for those who will be at the ASLM meeting next week, we wish you all the best. And we look forward to hearing more about what will have come out of the ASLM meeting. Again, to the panelists, thank you so much. And although the series have come to an end today, for sure the conversation will continue. It will continue at the ASLM meeting next week, but it will also continue thereafter. Thank you so much, and we wish you a great rest of your day.